So let's turn to the quantification of aortic regurgitation. I actually find it more difficult to quantify aortic regurgitation versus mitral regurgitation. And there are a number of pitfalls and problems, but if you take an integrative approach, as you will see, you can usually get to the right degree of aortic regurgitation. So the integrative approach that I'm talking about means that we are taking a look at the 2D image, we incorporate the color Doppler, the continuous wave Doppler, and the pulsed wave Doppler information to get to a diagnosis and to a degree of regurgitation. Let's take a look at the aortic regurgitation jet first. As with all jets we see in the heart, we usually have several components. We have a proximal component, which is called the PISA, or the proximal isovelocity surface area. Then we have the vena contracta, which denotes the region where the jet actually passes through the regurgitant orifice. Then we have the body of the jet, which can be measured in its length and in its total area or surface. So this again shows you a regurgitant jet and also where we would measure the vena contracta. If the vena contracta is below 3 millimeters or even not visible, we would quantify regurgitation as mild. If it's between 3 to 6 millimeters, moderate. And if it's above 6 millimeters, we can be quite sure that regurgitation is severe. Now this all looks very appealing. However, in clinical practice, it's sometimes much more difficult and there are a number of problems. Let's take a look at the problems. The first problem is that the regurgitant orifice is not always round, but that it is often shaped in a bizarre shape. So it depends on which view you're looking at. Second problem is that there's often blurring of the color, especially if you do not have good quality of the color jet, or if you don't have good 2D image quality as well. Another problem is if you have calcification of the aortic valve, then you will get a shadowing of the region where you actually want to measure the vena contracta. Let's also not forget that the measurements that we're performing are in a very small range, somewhere between 3 and 6 millimeters. So those measurement errors are very important and can also lead to misgrading of the regurgitation. And finally, a problem we often see is that patients have multiple jets. So in these situations, we cannot really use the vena contracta to quantify regurgitation. Let's take a look at another way of quantifying aortic regurgitation with the help of the jet. Well, we can look at the width of the jet and compare it to the LVOT. If it is below 25% of the LVOT, then we can consider regurgitation to be mild. If it's between 25 and 65% of the LVOT, it's moderate, and if it's above 65%, it's usually severe. Even though it's quite clear that the broader the jet is, the more severe regurgitation is, there are still a number of problems that you will encounter in clinical practice. First of all, what do you do with multiple jets? Second, it also depends on the width of the LVOT. It also depends on the resolution of the color, especially if you have poor image quality, and if you have blurring of the color, this can be quite difficult to perform at times. Then it's also dependent on the machine settings, on the lysing border, and it's also very difficult to quantify the LVOT jet ratio if you have eccentric jets, as in this example where the jet is directed towards the anterior mitral valve leaflet. Especially since we have a lot of energy loss if the jet is eccentric, and thereby it might be more severe than it actually is if you just quantify it based on the percentage of the LVOT. Another way of looking at the jet is by looking at the flow convergence zone. The flow convergence zone is large if the patient has severe aortic regurgitation, and it's small or not visible if regurgitation is mild. It is very difficult to really measure the flow convergence zone, but nevertheless you can look at it on a semi-quantitative basis. And there are other limitations, for example in this situation where we have a calcified aortic valve, where we do not see the PISA, and we also have multiple jets. Again, the size of the flow convergence zone also depends on the PRF limit, and it also depends on how good your color resolution is. So even with determining the flow convergence zone, there are a number of problems. So this shows you that it's quite difficult to derive quantitative parameters for the size and for the magnitude of the jet. But still, if we look at it from a semi-quantitative perspective, there are ways of getting to a diagnosis of how severe aortic regurgitation is. But now let's take a look at our patient, the patient we saw previously with the bicuspid aortic valve, and let's see how severe his aortic regurgitation is. Let's take a look at the severity of aortic regurgitation in this patient. We'll start with the parasternal long axis view. So this is the jet. And the first thing we notice right away is that the jet is asymmetric. It is directed towards the anterior mitral valve leaflet. And we also see that there is considerable amount of proximal acceleration, a fairly large flow convergence zone. Here, this would be the convergence zone in the ascending aorta, and the direction of the jet is towards the anterior leaflet. We will also try to measure the vena contracta, which is a bit difficult to do. Would be somewhere in the range of 0.6 centimeter, which is significant. Now, if we look at the area of the jet, we would probably underestimate the severity simply because it is asymmetric and because there probably is so-called Coanda effect, or we're losing a lot of energy since the jet is directed into the anterior leaflet of the mitral valve. We can also take a look at the aortic regurgitation jet in the short axis view. This gives us some information about where the origin of the jet is and also how large the jet is at its origin. So you have to move the transducer up and down to really find the area where the jet originates. Probably somewhere here. And so this is the region of the jet. In this case, it's probably very difficult to say how large the regurgitant orifice is because the jet is so eccentric. Then we'll go to the apical views and start with the 5-chamber view. Again, it's probably good to move the transducer in such a way that we are parallel to the jet. Okay, this would be the jet. There's a lot of color there because he also has elevated forward flow through the aortic valve. But we do see the flow convergence zone right here. This is the flow convergence zone. You can see it better here. And we also see that the jet is eccentric and it mixes with the inflow from the mitral valve. Okay, now let's also take a look at the regurgitation here in the apical long axis view. And we see that it is quite wide at the origin. So this again speaks in favor of an at least moderate to severe, probably even more than moderate regurgitation, probably somewhere towards severe. So even though it's not easy to assess the severity, especially in this form of jet, together with the other findings of regurgitation, we can come to a diagnosis with respect to the severity. So in summary, there's a number of problems if you want to quantify aortic regurgitation, especially if you have complex jets, eccentric jets, multiple jets, calcified valves, and machine settings play a great role. So let's take a look at a few patients. This patient has a bicuspid aortic valve, and you can see that the jet is fairly complex. The origin of the jet is all along the commissure line of this bicuspid valve, and so it does make a difference if you cut the image or cut the aortic valve in this direction or this direction, you will probably underestimate regurgitation in this direction and overestimate the jet if you cut it just along the line of closure. This is an example where you have a very eccentric jet. In this case, you do not even see the vena contracta and you do not see the proximal flow convergence zone, and you cannot really calculate a ratio between the jet and the LVOT since it's just crossing the LVOT. Another problem that you encounter sometimes is in patients who have a very high heart rate. You can note here that the jet is very difficult to see because diastole is so short. So this also makes it quite difficult at times. Another example we saw previously is heavily calcified valves do not allow you to see the portion of the jet which lies above the aortic valve. So you cannot look at the flow convergence zone and you do not see the vena contracta. This shows you what happens if you change the machine settings. The same patient, we just changed the PRF here from 0.69 to 0.48. Just by changing the PRF, you do get the impression that the jet gets larger if we reduce the PRF. A good way to look at aortic regurgitation is also the short axis, because in the short axis you see the origin of the jet quite nicely. For example, in this example you see that it originates from the center here of the aortic valve, opposed to this patient where you see that there are multiple jets, one arising from here and another one arising from here. And thereby you can also kind of semi-quantitatively look at the origin and the size of the origin of the regurgitant jet, and that also helps you in assessing the severity. Put all these things together, it will not be difficult at most times to really quantify aortic regurgitation just by looking at the size and the different features of the jet. This is just to show you how we would quantify aortic regurgitation. This patient has only trace aortic regurgitation. You hardly can see a jet here. There's no flow convergence zone you see. This is a patient who has mild aortic regurgitation. A very small blue flame can be seen here. But again, no flow convergence zone, and the vena contracta is not hit in this image either. Moderate aortic regurgitation, you see that the jet is nicely visible. We do see that there's a very small flow convergence zone here. And this is a patient who without doubt has very severe aortic regurgitation with a broad jet, with a jet which encompasses almost the entire LVOT, and with a very, very large proximal flow convergence zone. Now let's look at the 5-chamber view, which is also very helpful, especially in situations where the jet has a more central orientation. And again, we have 4 different degrees. On the left upper side, we have just trace aortic regurgitation. Here we have mild aortic regurgitation, moderate aortic regurgitation. Here we see the flow convergence zone and the vena contracta. And finally, here we have a very severe aortic regurgitation. How helpful is transesophageal echocardiography? This is a very nice image where you see the aortic regurgitant jet, which is pointed towards the anterior leaflet, and which actually moves this direction with the opening of the mitral valve. You can see the flow convergence zone here again and the vena contracta. Now those images are very good and of course very helpful, but TE is not always necessary to quantify aortic regurgitation, and there are a number of limitations. Well, what are the advantages of transesophageal echocardiography? Well, the first thing is we're quite close to the aortic valve, which means we can use transducers with a fairly high frequency, which enhances the resolution of the image. So this is one big advantage. The color resolution is also better, and the main advantage, I believe, is that we can look at the aortic valve and its morphology and thereby get an understanding, as we saw previously, of the mechanism and of the etiology of regurgitation. However, as a limitation, we're sometimes not oriented optimally with respect to the jet. So there are advantages and disadvantages, and I would say that in most patients you do not need transesophageal echocardiography to quantify aortic regurgitation. There are other ways of also looking at the degree of regurgitation, and that is by looking at the spectrum. Let's go back to our pressure tracing we saw previously. we saw that there is a more rapid decline in pressure equilibration between the left ventricle and the aorta. This can also be seen in the Doppler spectrum. If we use a continuous wave Doppler spectrum across the aortic valve and through the regurgitant jet, we will see a spectrum which resembles a curve which looks like the curve we see here. Very important, the steeper this curve is, the more severe regurgitation is. In other words, we have less gradient between the left ventricle and the aorta at the end of diastole. Let's take a look at two examples. This is an example of a patient with mild aortic or mild to moderate aortic regurgitation, where we have a decline of the curve which is not very steep, opposed to a patient here on the right, where we have a very steep deceleration time and only a low gradient at the end of diastole. The problem is that we do not get the spectrum in all patients, depending on how eccentric the jet is and how good the image quality is. So I would say probably only in 50 to 60% of patients can we use the continuous wave Doppler spectrum. So how can we grade the severity of aortic regurgitation based on the continuous wave Doppler spectrum? Well, first we have to perform a pressure half-time measurement, similar as you would do it with mitral stenosis patients. Then we would calculate the pressure half-time, and if it's between 500 and 600, I would say above 600, then regurgitation is definitely only mild. If it's between 200 and 500, it's moderate, and if it's below 200, it's severe. The problem is that in reality, even patients with pressure half-time in the range of 300 or 350 can still be severe. So there is an overlap in this region. But now let's take a look at our patient, and let's take a look at his continuous wave Doppler spectrum. I will now show you how to use the continuous wave Doppler spectrum to quantify the severity of aortic regurgitation, and I also want to show you how problems can arise and how difficult it sometimes can be, and what the limitations of this technique actually are. So, in principle, you would start with a 5-chamber view. Try to orient the 5-chamber view in such a way that you have a parallel orientation towards the ultrasound beams. Then we would place the region of interest with the color Doppler to give us guidance where the jet is, and with the continuous wave Dopplers we will then try to go right through the origin of the jet, which we're trying to do here, and then we would get a spectrum, in his case, which looks something like this. Now, in reality, we should not use the spectrum simply because we do not have a very high velocity. In other words, we're not aligned optimally, and we cannot really see the contour of the spectrum. So in this patient, simply because he has such an eccentric jet, we cannot use the continuous wave Doppler spectrum to quantify aortic regurgitation. So even though the principle is good, it does not always work in all patients, and we have to consider that there are a number of limitations if we use the continuous wave Doppler spectrum. First of all, the jet alignment is important. If you do not have good jet alignment, you will not get a very good jet, and you do not get a good delineation of the deceleration. And if you do have a velocity which is below 3 or 4 meters, this is probably not a good signal, and I would not perform it in these patients. Even if you do get a good signal, we have to consider that these measurements are dependent on preload, afterload, and the compliance of both the aorta, and also dependent on the compliance of the left ventricle. Personally, I believe that looking at the retrograde flow in the descending aorta gives you more information or more reliable information than assessment of the continuous wave Doppler spectrum. This is a suprasternal view of a patient with significant aortic regurgitation, and what you see here is the descending aorta and the aortic arch, and in the color tracing you see that there is retrograde flow regurgitating back towards the left ventricle in diastole. We can use color, but we can also use pulsed wave Doppler to look at the amount of regurgitant flow. This is such a tracing which shows you severe regurgitant flow. First of all, we have a lot of antegrade flow as well. And then we have a very high initial velocity of retrograde flow and an holodiastolic flow, which both denote severe aortic regurgitation. The cutoff value for the maximal retrograde flow is somewhere in the range of 32 centimeters per second, but more importantly, always take a look at the duration of retrograde flow and if it is really holodiastolic. One thing that you always have to be careful with is in patients who have a dilated aorta, because in those patients these values might not apply simply because the aorta is very wide and therefore the amount of blood which regurgitates spreads, and therefore the velocities might not be as high, and it also depends very much on where you place the sample volume to get these spectrums. With all this background information in mind, let's now go back to our patient and let's take a look at his retrograde flow. I always find it very important to also look at the retrograde flow in the aorta, the descending aorta, to quantify regurgitation. How do we go about? We image from a suprasternal position. This is the descending aorta here. And I usually start by looking at the color Doppler first. And what we look at here is the red flow which goes towards the transducer. This is the retrograde flow. So we do see considerable retrograde flow here already in the color Doppler. And then we place the post-wave Doppler sample volume in the descending aorta. And what we get is a signal which looks like this. This is the elevated antegrade flow down the aorta, and this is the retrograde flow, which is holosystolic. And holosystolic flow usually means that there is significant aortic regurgitation. So if we take all the points together, we have retrograde flow, which is significant. We have pretty much flow convergence zone. We have a fairly wide vena contracta. We have an asymmetric jet, which we do tend to underestimate from the severity. And then we also have the 2D image with volume overload. So in conclusion, the patient has significant aortic regurgitation. But there are also other ways of looking at regurgitant flow. We can perform hemodynamic assessment by calculating flow across the mitral valve and the aortic valve, and thereby calculate regurgitant volumes and fractions. And we can also do so by using the PISA method. Let's just briefly look at the principle. Briefly, if we have regurgitation, we have regurgitant flow going back to the left ventricle, and thereby an elevated flow through the aorta. If we calculate the flow through the aorta and subtract it by the flow which comes into the left ventricle via the mitral valve, we get the actual volume or regurgitant volume. This is the way we would grade the severity of regurgitation based on the volumes, the fraction, and the effective regurgitant orifice area. If you want to have more information, please go to the fact sheet. There you will find the formulas and also how to perform the quantification based on hemodynamic assessments. Most patients you see will have chronic aortic regurgitation, but there's also acute onset of regurgitation, which looks a bit different. This will be the topic of the next chapter.